Welcome to the Politics Guys. I'm Michael Baranowski, a political scientist at Northern Kentucky University. My guest today is Dr. Bob Pendleton, Chief Medical Officer at University of Utah Health. We'll be talking about the school's recently released Value in Healthcare survey, which asked patients, doctors, and employers across the country about their perceptions of value in healthcare and how they prioritize quality, service, and cost of healthcare services. Dr. Pendleton, welcome to the show.
Thanks so much. It's great to be with you.
To start with, can you talk a little bit about how this survey came about and why you decided to focus on value?
Yeah, I think the backstory is the national conversation around the total cost of healthcare in the United States. Currently we spend $1 in every $5 in our entire economy spent on healthcare. And part of the conversation nationally to start to deal with that has been moving the tagline is moving from volume to value, where value has now become probably one of the most overused terms in healthcare, and largely has been driven as political propaganda, being driven by policymakers and special interest groups. And when we reflected on what value really means, we felt that three critical voices have been really not heard loudly enough. And those are simply those who receive care, those who provide care, and those who pay for care. So our patients, doctors, and employers. And our sense was that those three voices may not be aligned. And if we didn't give those three critical voices sort of a stage and a platform, we never will be able to come to really a shared vision as a country on what we really mean by this transition to value-based care.
That makes a lot of sense. I wanted to ask you about that term value. It seems, I think, can mean a lot of different things to different people. And I'm wondering how you conceptualized or defined it kind of going into this.
Yeah, it is one of the problems, isn't it, that it has become, vague and really ill-defined. I think one of the most interesting voices has been from Michael Porter, a professor at Harvard Business School, who has popularized the definition of health outcomes achieved per dollar spent over a full episode of care. And as an example, if a patient has problems with their hip and they need a hip replacement, that Michael Porter's definition would be that we really should be thinking about what are the outcomes achieved from that hip replacement, and then how much does it cost from the very first visit we have at the doctor's office until we're fully recovered. For us, we agree largely with that definition, but also have felt that one of the missing elements of that definition is really the voice of our patients. And, patients, we bring another dimension to this where there are things like accessibility and convenience of healthcare carries another, layer of importance. And so we define it as outcomes and service per dollar spent.
Okay. Now, in looking at how patients versus physicians answered some of the survey questions, one thing that really stood out to me was this idea of quality. It was the most important component, both for physicians and patients, but there was a big gap. 88% of physicians gave that response, but for patients, it was 62%, still a majority, but a 26% difference. And I'm wondering, what do you think accounts for that?
Yeah, I think, for providers, I think it reflects the sort of the altruistic nature of doctors and sort of viewing, their role as making patients better. But for patients, I actually think that reality represents, or that gap represents our patients' reality. And, patients have an increasing cost burden. More and more patients are on high deductible health plans. Those who are even on normal, sort of typical health plans are paying more and more out-of-pocket costs for medications, tests, and treatment. And so this financial burden for patients is problematic. patients may not value getting better quality of care if it's at the cost of losing their car or their house, as an example. And healthcare expenses is still the number one reason for personal bankruptcy in the United States. So I think for patients, that gap reflects their reality. In another dimension, for patients, it's easy for doctors to say, well, take the day off of work and drive to see me in clinic and wait, and we'll take our time and get you taken care of. But for a patient, there's an enormous and I think increasing burden on actually being able to do that. So again, I think these other things in terms of accessibility, convenience, and cost are the reality of most patients who are just trying to juggle everything in their very busy lives.
Absolutely. That's a unfortunate reality, I think. I wonder, in most markets for goods or services, cost is a huge consideration, obviously, both for consumers and for providers. But in the survey, I noticed only 5% of physicians said that cost was the most important component of value, and 26% of patients did. And so I was wondering if you could talk a little bit about what that result suggests to you.
I think there's an upside and a downside to that. That we do want our providers, those who deliver care, to have the outcomes of that care perhaps be the most important thing. But I think that the challenge is that focusing solely on quality and outcomes is not enough. And I think providers need to continue to evolve and put that altruistic priority on quality and outcomes in context for individual patients, because for patients, treatment decisions are a value proposition, and it is about weighing, one treatment option versus another, both in terms of impact on their health, but also their out-of-pocket costs. And as an example, providers may see a patient, say, with asthma, and they may have two options for inhalers for that patient. And they may know that one of those inhalers, the patient may have slightly better outcomes in terms of how their breathing is and their risk of needing to come to the hospitalization. But that slightly better outcome, which the doctor puts priority, may cost twice as much for the patient out of pocket. And so we can prescribe that, but if we don't understand that the patient's not going to fill the medication because they can't afford it, then we're really working against ourselves. So I do think that doctors prioritizing quality as the most important thing is a good thing, as long as we continue to equip both doctors and patients with the ability to talk about and put that quality in context of costs.
That's really interesting. It actually relates to a personal experience I had not too long ago. I went in for an eye exam and got a prescription for some drops, and the doctor said, well, I can prescribe this non-generic. I think it's a little bit better, but you'll pay more, or this other one. And he gave me that option, and which I really appreciate. I ended up going for the more expensive one, but it was nice that I felt it was nice that my physician was aware of that and gave me that option, made me understand what my choices were there.
And we make those value propositions in every part of our normal life outside of healthcare, right? If I buy a car, I decide whether I want to pay more for leather seats or upgrade the radio or have Bluetooth technology, or if I buy a house, I decide whether I want that extra bathroom. So those value propositions we're used to making all the time. And so I think the survey, that comes out pretty loudly by patients. They want healthcare, they want to be enabled in healthcare to be able to weigh those same value propositions, whereas providers, I think their voice to a large extent was they understand that, but they're still pretty grounded across the country in terms of a singular focus on quality and less so kind of the whole part of the value proposition.
Right. Now I noticed one group that was definitely very focused on cost was was employers, and that makes sense in a largely employer-based system where they're seeing a lot of those direct costs. I mean, in the survey, the top two value statements that they gave were cost related, both on cost to their employees and cost to the company. So I'm guessing this didn't surprise you that much.
Yeah, not really. I mean, I think that we oftentimes forget that, over half of our entire healthcare bill in the country is paid for by our employers. A typical employer will spend an average of $9,000 per employee per year on just healthcare coverage. So cost is critical to employers, and I think that some of the national conversation around that, making a lot of our businesses less competitive in a global market. There's some strong legitimacy to that with the cost of healthcare that they're burdening.
Yeah, definitely. Yeah, there was another way that you got at concerns about cost in the survey was asking if people agreed with the statement, the overall cost of healthcare in this country is too high. And just about everyone agreed with that. It was 83% of patients, 84% of employers, and 89% of physicians. And it's that physician number that surprised me a little bit. U.S. doctors earn on average around twice as much as doctors in other wealthy countries. But I'm guessing that despite this, doctors probably don't see their high salaries, at least comparatively speaking, as part of the problem, or do they? I don't know.
Yeah, I think that's a great and insightful question. So as the doctor side of me says, well, of course we're not part of the problem, but I think that I think the doctors clearly understand the global costs of healthcare are too high in the United States. Doctors also are the ones that really do see the inefficiencies in our fragmented healthcare system. That said, I think that doctors are much like every other player in the healthcare sector, where we think that the primary sort of driver of higher costs is someone else, whether that's pharmaceutical, whether that's IT and tech companies, whether that's hospitals, and yeah, I think doctors are very much in that group as well, where we all agree that cost is a problem. We just point the finger in a different direction, and the reality is there's culpability across the board, and I think everyone sort of shares responsibility, and ultimately long-term success in temporizing costs of healthcare in the United States are really we're going to require everyone to do their part, and yeah, including doctors.
Yeah, definitely. Now, one thing that some on the right especially talk about is the costs of what's called defensive medicine, ordering more tests than you might necessarily need in order to protect yourself from a potential lawsuit. And I noticed in the survey that physicians indicated they're very concerned about ordering the right tests and the right labs. In fact, in the survey, it ranks even higher than the patient's overall or the patient's health improving. And I was wondering if you think that's due to a concern about lawsuits.
Yeah, I think that's a good question, and there's clearly some evidence that would suggest that that is a contributing factor, and that it does weigh in, doctors' decisions about test ordering. That said, I think that there is a continued movement, really led effectively by a number of national physician societies, like the American College of Physicians and others, trying to shift that frame of reference for doctors away from worrying about medical legal liability and focusing much more sharply on both the harm that over testing and overutilization can cause. I mean, every test that we do has some risk to it, even something as simple as a blood draw. And so there is a pretty strong movement about that we really need to be focusing on what's appropriate, what's the right thing to do for patients, that gives them the best outcome. And then if we can factor costs into that as well, then again, I think we're a long ways towards this value proposition. But I do think that there are certainly some providers in some areas where the concern of medical legal liability is a contributing factor.
Yeah, one thing I wanted to ask you a little bit about is you mentioned that every test has a risk, and I think a lot of people maybe don't quite grasp that idea. And at least when I hear you say that, I think in terms of the cost of false positives. And is that one of the big
Yeah,
things that is involved with that?
absolutely. The risk of false positives, and people say, well, what does that mean for me? Well, you can imagine that if you're a middle-aged woman who undergoes a mammogram to screen for breast cancer, and that the mammogram, which is not a perfect test, there is no such thing as a perfect test, has some, small area that's probably not cancer, but it's a little hard to tell. That could in turn lead to, a biopsy that's unnecessary, and even as far as surgery that's unnecessary. And so that false positive, it's not just the false positive, but it is the additional care that leads to, which usually is more and more invasive, which then really carries true risks, things like infections and blood clots and other complications that are really an important and potentially devastating part of care delivery. So if we sort of go upstream and make sure that we're not doing unnecessary tests in the first place, we can really mitigate most of that.
Right. Now, I've heard that another part of that sometimes is the fact that some of this scanning machinery equipment is incredibly expensive, and so it's been said that if a hospital or clinic buys say an MRI machine, they want to use it to recoup the enormous costs of that sort of thing. Do you think there's something to that, or is that somewhat overblown?
No, I think that I do think that there is a lot of legitimacy to that. A lot of these, it's easy to talk about kind of appropriateness and care decisions for patients, but most of the time these decisions are not completely black and white, but rather some shade of gray in between. And so then the question becomes, when we have a payment system that incentivizes us to do more rather than to do less, if we're caught somewhere in the middle, which way do we lean? And there are a lot of well-designed studies that I think pretty clearly say when we have a payment system that incentivizes us to do more for these gray area decisions, we tend to lean that way, and that is very much a contributor to increased cost in the United States.
Yeah, I think a lot of people want to sometimes look at this in terms of good guys and bad guys, but I think that idea of incentives is so critically important. And when you look at where the incentives are stacked toward it, it only makes sense. And it's not like people are necessarily trying to cheat or make money, by doing unnecessary tests, but so much seems to push in that direction in the healthcare industry.
Yeah, absolutely. And clearly there are a few bad apples. Those get brought up every once in a while. But that's really, those occasional bad apples are not where our opportunity is to improve care and lower costs in healthcare. It is the global incentives for everyone on these sort of middle of the road decisions that patients and doctors struggle with, day in and day out to try to navigate.
Right. There was another result in the survey I found really striking. It's what you think would be the most important thing, at least what I would think would be the most important thing, getting better, wasn't actually the top value statement for patients or physicians. I mean, physicians rated it third below, let's see, knowing and caring about patients and ordering the appropriate tests. But patients rated it amazingly eighth, below things like location of the office and friendliness of the staff. I got to say that blew me away. Were you surprised at that?
Yeah, I was surprised and disappointed. As a physician and a chief quality officer who's trying to help people get better in both my, patient care and my administrative roles. I thought that was really disheartening. And so then the question is, well, why is that? And although our survey, didn't get exactly at the why, I think that it does get at this notion that we don't actually have a really good way to measure getting better. We measure a lot of things in healthcare that we call quality, but most of those are really, compliance with prescribing the right medication or ordering the right test. What we really need to move towards is actually being able to measure getting better. And I'll give you an example. So, patients, I mentioned earlier that gave an example of a patient undergoing a hip replacement. And currently in healthcare, if I were to undergo a hip replacement, I would my doctors would define quality by things like avoidance of major complications and whether I adhered to prescribing the right antibiotic around the time of surgery. Now, for patients, I don't know about you, but those sound like my expectations, not sort of envisioning what I really went and got my hip replacement for, which is probably things like I want less pain and I want to be able to get back to golfing like I was, a few years ago. And until we actually measure those things of getting better, and highlighting for patients that that's part of the valued choices, that not all providers and not all procedures and tests will lead to the same actual outcomes. Once we can measure that and give patient that information, that I think will be a powerful enabler for patients. And again, it may be that one doctor who does a hip replacement, the best getting better outcome I can have might be being able to walk down the street, whereas another, I might actually be able to run a marathon. And those would be powerfully informing distinctions for patients. But I think because we don't have that information, patients don't quite know what to even think about this. So there's this almost apathy, and because of that, all of these other things became a bigger priority on the results of the survey. But it was absolutely disheartening to me, and I think it's a real opportunity for us.
Because it seems to me that healthcare isn't something. Healthcare services, they aren't something you can sort of compare and contrast like you would say like an Android and an iPhone or something like that. I mean, when you mentioned a hip replacement example, for instance, the first thing that came to mind for me was, well, some people's hips are in worse shape, and some patients don't really do a whole lot of their physical therapy, and there are a million little things. And boy, that just sounds like a incredibly difficult thing to try to sort through all of that stuff to try to develop some sort of apples to apples comparisons.
It is, and you're right. There's a lot of those, and historically, those nuances that you mentioned have paralyzed progress in this space. But one of the things I'm encouraged about is there are measurement systems that we call patient-reported outcomes that have evolved to the point that we are now able to account for most of those variables to actually create apple-to-apple comparisons. So the optimistic side of me says over the next 5 to 10 years, there's going to be that kind of meaningful information that patients can use to help make informed healthcare decisions. And so then my hope would be if we were to redo this survey 10 years from now, that sort of a valuing of outcomes and getting better would move up to be the most important, if not one of the top one or two most important things.
Right. And we, correct me if I'm wrong, but we have pretty good evidence that once we're able to make those sort of quality, quantify those sort of quality things, that really matters. I'm thinking about, didn't a few years back Medicare change their policy in terms of payment for readmissions for infections, I believe, and then the rate of infections dropped considerably once that became a factor. Is that am I remembering that correctly?
You are, and the Medicare story is an interesting one, and there's a lot, I think, of lessons learned to do better in the next 5 to 10 years. And on one hand, having the information and creating transparency to allow hospitals and providers to know how they perform compared to others, that in of itself is motivation for improvement. On the flip side, if there's too much in the way of financial penalties, the other thing that the Medicare story I think has taught us is that people will try to game the system. And so there were a couple of recent studies on readmissions to say, well, gosh, maybe some of that benefit had more to do with people gaming the system than better care. But I think those are really important policy insights that my hope is over the next 5 to 10 years we can learn from and do better in this space.
Yeah. One of the questions asked in the survey was whether U.S. healthcare is the best in the world. And I guess I wasn't really surprised to see that just under half of patients felt that it wasn't, but only 48% of physicians agreed that U.S. healthcare was the best in the world. And that did surprise me a little bit. Why is that, do you think?
I think doctors see the incredible fragmentation of our healthcare system, that we really, a typical patient doesn't just see, a single doctor. They see, a primary care doctor and maybe one or two specialists, and they might need to go to the emergency department or Instacare, and they get their medications filled at their pharmacy down the street. And I think doctors see that all of those important players in helping the patient get better are not well coordinated, and that has negative consequences for our patients. So I think doctors and I would say actually a lot of patients recognize that our strength in U.S. is what I call rescue care. So if I were to, get involved in a car accident on the interstate, or, fall off a bridge, or, have a heart attack, we probably are the best in the world at those immediate life-threatening situations, in getting people to care quickly, and in them providing amazingly effective care. It's everything else short of that that I think we can do better. And again, I think the doctors really see that in their day-to-day practices.
Yeah. Now that issue of coordinated care, it seems to me that kind of bumps right up against the patient's desire to be able to choose whatever physician they want. I mean, I know there are some systems who have had a certain amount of success with coordinated care, but I feel like it's been much more difficult to roll out on a large scale basis because people want to be able to go to whatever doctor they happen to choose. Is that fairly accurate, would you say?
Yeah, I think that there is a consumer choice piece, and I actually think that we shouldn't need to take that away, because patients do have lots of things, cost and convenience, that really are important, that I think we need to value. But there's also, I think, challenges in terms of financial disincentives really to coordinate care. In other words, no one in healthcare gets paid more to ensure that um, doctors communicate effectively with each other. And doctors at a hospital sends patients to a nursing home with a smooth transition. That we currently have no sort of financial alignment to actually help with those transitions.
Right, and that gets into right the heart of what some people say is the fundamental problem with our system in the United States is the fee for service nature of it, as opposed to sort of a capitation type of system where you're focusing on individual overall outcomes as opposed to being paid by the number of tests or procedures. Right.
Yeah, I mean, our financial system incentivizes us to do more, and doesn't incentivize us, or really penalizes to deal with the care gaps and transitions and better care parts. So I think until we sort of reimagine that, and part of, again, the whole purpose of this survey was, well, what are some of the things that are important for us to do that? Because again, without the voice of a patient, we might undervalue how important it is for a patient to have an Instacare clinic, within a 5-minute drive of their home. But if you don't, then patients will behave like consumers, and They're not going to drive 20 more minutes to go to an Instacare if there's an emergency department 5 minutes from their home that might carry, twice the cost. So that patient voice on things that are important to them is one of the reasons why, again, we really wanted to sort of help paint this picture of a sort of shared needs and understanding of how we need to think about healthcare improvement.
Yeah. I want to end with what I think is maybe the most important question, I guess. Where do we go from here? I mean, how do you think this information could potentially be useful to policymakers and decision makers in the healthcare sector?
I think for policymakers, my hope would be that this creates some tension and better definition of a path forward. And I'll give you an example. As a country, we are at a crossroads in my mind where the one certainty is we have to curb healthcare costs. And so we can do that in a couple of ways. We could have policies that are a blunt instrument where we just focus purely on the cost under the veil of value and don't worry so much about the things that this survey would say are important to patients and providers, which is accessibility, communication, coordination, better outcomes. Or the other policy path is, how do we take these collective voices and really reimagine a healthcare system that does temporize costs, but also brings these other equally important facets into the conversation. And then on a practical, I would hope that this survey drives some tension to say that if we want patients and providers to have the kind of value proposition conversations, we need to equip them with the information and the tools to be able to do that. Even if most of our doctors wanted to have a conversation with a patient about one treatment option versus another, they may have no idea about the cost differences between those two. And until we enable providers and patients with that information to have that as part of their conversation, then again, it's going to be hard to move forward. And I think that would be another sort of outcome of this survey.
Yeah, absolutely. Let's hope so. More information and more transparency tend to be good things for sure. And this, I think, is a step in that positive direction. All right. Well, with that, we will close. Dr. Bob Pendleton, thanks so much for taking the time to talk with me today.
Yeah, thank you.
That's it for this episode. Thanks for listening. We hope you liked what you heard. Listener support is a really big help to us, and we truly do appreciate it. If you're interested in joining our great group of Politics Guys supporters, you can go to politicsguys.com and click on the Patreon link. And if you'd like to support the show without spending anything, it really does help if you get the word out by sharing this episode with your friends and followers or passing along our new show posts and tweets on Facebook and Twitter. Leaving reviews and ratings on iTunes also does really help. If you'd like to get in touch with us, you can do that at mail@politicsguys.com or through our Facebook page where you can message us and we post stuff throughout the week. That's facebook.com/politicsguys page. We're also on Twitter @politicsguys. The executive producers of the Politics Guys are Michael Baranowski, Jay Carson, Trey Orndorff, and Bruce Johnson. Today's show was produced by Michael Baranowski. We'll be back with a new show on Saturday. We hope you'll join us.